Assalamu alaikum. Hello everyone. We're gonna start in a minute or so. So just give me a second here. So assalamu alaikum everyone. Welcome to our Zoom meeting. Today we're gonna talk about different topics. So Dr. Fatma and Dr. Mohamed will start. The first topic will be about kidney disease in older adults. Dr. Fatma, when you are ready, please go ahead. Thank you.
Okay. Hello everyone, Ramadan Mubarak. Wishing you all the best in the coming year and may Sudan regain its security and peace. I'm Dr. Fatima Tahir. First, I would like to thank Dr. Nader for giving me this opportunity and for his support to all of us. No matter how much I thank him, I can never fully express my gratitude. Today, me and Dr. Mohamed will be the presenters. I will present chronic kidney disease in geriatric patients, and Dr. Mohamed will present AI prompts, artificial intelligence prompts. So now we will start with kidney diseases in older adults. The objectives, we have to know and understand how age-related anatomic, hemodynamic, and hormonal changes affect kidney function. The most practical method of monitoring kidney function in older adults. Also, we have to know understand how to recognize and manage the kidney diseases and disorders that are most common in older adults. At what point patients with chronic kidney disease need referral to a nephrologist and renal dietitian. So the topics will be covered in this presentation are aging kidney, electrolyte disorders, nephrotic syndrome, renovascular disease, acute renal failure, chronic kidney disease, and end-stage kidney disease. I will start with declines in kidney function with aging. So we have kidney have many functions, and this function will decline with aging. The first function is glomerular filtration rate. And there are, as we know, GFR decline have many mechanisms. I will mention some examples, not all of them. So there are several mechanisms leading to decreased GFR with aging. For example, we have glomerulosclerosis, and this will occur even in the absence of any comorbidity. And if there are comorbidities, this will increase the chances of glomerulosclerosis more. Like these comorbidities like hypertension. Also, there will be overall number of functioning nephrons will be decreased steadily with aging, and individual functional glomeruli reveal both structural and functional changes. And also we have biological mechanisms leading to decrease in glomerular filtration rate. For example, progressive change in vascular tree, which is related to the effects of oxidative stress and telemetric shortening. There will be decreased volume of renal cortex, which is diminished in concrete with the loss of nephron mass. So the clinical significance of decreasing glomerular filtration rate is increasing susceptibility to acute and chronic kidney disease. Then the second function declining, we have sodium conservation. How this will happen due to decrease in distal tubular sodium reabsorption, renin levels, and activity, and aldosterone levels. And this will, the clinical significance increase susceptibility to hyponatremia from salt loss caused by excessive diaphoresis, GI losses, etc. Sodium excretion function due to decrease in GFR and response to atrial natriuretic peptide. And the clinical significance increased percentage of nocturnal sodium load excretion, contributing to nocturia and susceptibility to hypernatremia. So continuation of declines, we have renal concentrating capacity, and this is due to decrease in tubular water transport in response to arginine vasopressin release. And the clinical significance is decreased response to hyperosmolar and volume-deprived conditions. So this is why, if the older adults will be in hot climates, this can affect their mechanisms of cooling and stuffs. Then we have renal diluting capacity. The mechanisms are unclear, but it may be due to decrease in GFR. And the clinical significance of renal diluting capacity decline is decreased response to hyperosmolar and volume overloaded conditions. Then we have acid and ammonium excretion. This is due to decrease in GFR and renal mass. And the clinical significance increased susceptibility to metabolic acidosis. Then I will talk about monitoring kidney function. The GFR is the most important indicator of kidney function in older adults. The most commonly used and practical method for estimating GFR is calculate creatinine clearance. And we can calculate the creatinine clearance using the Cockcroft-Gault equation. The MDRD formula, we know MDRD is stand for modification of diet in renal disease. Hasn't been validated in adults more than 7 years old, and it is unreliable at extreme weights and extreme age. So determining the actual GFR is by performing a 24-hour creatinine clearance measurement can be useful. This is calculated creatinine clearance versus serum creatinine. We have the red one, age 85, and the black one, age 65. And on x-axis, on the left one, we have the calculated for a 70 kilogram per man in man and woman. So there will be decrease in the calculated in men and women, and this is due to the muscle mass. So also, as we see here, I don't know, do you see my cursor? Because I don't see it, I don't know if you see it or not. So here, when we notice that at the age increase, the creatinine clearance will decrease. So kidney function can be profoundly impaired even if serum creatinine concentration is normal. So this means that if we have normal serum creatinine concentration, we can't say that the patient is not doesn't have renal impairment. So we have to be cautious about that in elderly people. Then the next topic will be electrolyte disorders. Are you good? Everything is okay now? Okay. If I'm so fast or anything, let me know, please. Okay, we have the precipitance of osmolar disturbances. We have decreased thirst sensation in older adults. Impaired access to fluids and or sodium. Fluid and or sodium loss from diarrhea, vomiting or diaphoresis. Volume and pressure changes related to surgery. Increased fluid intake. Medications, especially diuretics, particularly thiazides and non-steroidal anti-inflammatory drugs. Conditions and medications that cause syndrome of inappropriate antidiuretic hormone secretion. Comorbidities, especially cardiac and hepatic dysfunction. Just a minute, because this is covering that one. So recognizing hyponatremia. Generally, hyponatremia will be asymptomatic until serum sodium concentration less than 125 milliequivalent per liter. So then what are the consequences of hyponatremia? Hyponatremia can cause brain edema, and this brain edema can manifest as apathy, disorientation, lethargy, muscle cramps, anorexia, nausea, agitation, headache, and seizures. If hyponatremia develops rapidly, there will be manifestations of muscular twitches, irritability, and convulsions. The only manifestation of chronic hyponatremia may be lethargy, confusion, and malaise. This means that manifestations of hyponatremia depends on is it acute or chronic, developing rapidly or slowly. Treating hyponatremia. The treatment for hyponatremia is different. So if the patients are asymptomatic and they have hypovolemic hyponatremia, and there is hypotension, we have to give isotonic saline to replenish intravascular volume. If the patients are asymptomatic, but they have hypervolemic hyponatremia or syndrome of inappropriate ADH, we have to do water restriction plus or minus loop diuretic. So asymptomatic, it depends. Is it hypovolemic or hypervolemic? But if the patients are symptomatic, always we have to treat it. And how we treat it? IV hypertonic saline. Then I will talk about hypernatremia. Major risk factors for hypernatremia in older adults are impaired thirst, immobility, depressed level of consciousness, systemic illnesses, infections, fever, dementia, and neurologic disorders. The neurologic sequelae for hypernatremia can include obtundation, stupor, coma, and death. We have to correct free water deficits by administering IV dextrose or enteral free water. So for hypernatremia, always we have to treat, not like hyponatremia, regardless, symptomatic or asymptomatic. Then we have disorders of potassium balancing. We have hypokalemia in older adults, generally results from renal or GI loss of potassium. Inadequate intake can contribute, and usually we treat it with oral potassium. Hyperkalemia is most common with chronic kidney disease and acute conditions causing acidosis. In minor cases of hyperkalemia, we have to restrict potassium-rich foods. I have some examples for potassium-rich foods, like cooked spinach, cooked broccoli, potatoes, both normal potato, regular potatoes and sweet potatoes, mushrooms, peas, cucumbers, banana. So we have to do only this in minor cases. In addition to foods, we said we have to discontinue associated medications, and we have to use loop diuretic. In more severe, for example, if the potassium level is 6 or more than 6 milliequivalent per liter, or refractory cases, we have to add sodium polystyrene sulfonate orally or rectally. If we have signs of cardiac toxicity or very high serum potassium, we have to do emergency treatment. Then I will talk about introduction to nephrotic syndrome. Nephrotic syndrome defined as urinary excretion more than 3 grams of protein per day with associated hypoalbuminemia, hyperlipidemia, edema, and hypercoagulable state. Hypertension and renal failure are seen in about 1/3 of cases in older adults. It can result from primary glomerular disease or from infection, malignancy, exposure to allergens or medications, or multisystem disease. Renal biopsy is essential for early diagnosis and appropriate therapy. Because we have different causes, so renal biopsy, we have to know like the cause and treat the cause accordingly. Then I will talk about membranous nephropathy, which is most common histopathology associated with nephrotic syndrome in older adults, about 54%. We have, most patients have idiopathic disease, but we have secondary causes of we have secondary membranous nephropathy can be caused by NSAID use and malignancy, which are the 2 most common causes of secondary membranous nephropathy. We have up to 20% of patients have solid organ tumors. The prognosis for older adults is quite variable and correlates somewhat to the severity of the syndrome. The therapy includes corticosteroids, cytotoxic agents, for example, rituximab, or combination. We can use either one, or we combine both corticosteroid and cytotoxic agents together. The next topic will be minimal change disease. Is one of the causes of the nephrotic syndrome. The minimal change disease can be idiopathic or associated with tumors and hypersensitivity reactions, particularly to NSAIDs. The minimal change disease has the same clinical presentation in older adults as in younger individuals, like acute renal failure, but there will be more severe acute renal failure, more severe proteinuria, and lower albumin levels are more common in older adults, but otherwise it will be same as in young adults. Up to 80% of older patients respond to initial therapy with steroids, but with relapse rates up to 33%. Current treatment recommendations include a trial of steroids followed by cytotoxic agents if steroids are not tolerated or are ineffective. So we have to start with the steroids. Then the second option will be cytotoxic agents. Amyloidosis. For evaluation of amyloidosis, we have to do a renal biopsy or abdominal fat pad biopsy, stained with Congo red or cyflavin T. Renal tissue should be examined by electron microscopy for myeloid fibrils. So we know that the common cause of amyloidosis can be multiple myeloma. So paraproteinemia can be found in up to 68% of patients with primary amyloidosis. Order both serum and urine immunoelectrophoresis for all older adults with nephrotic syndrome. If findings are abnormal, then we have to order the bone marrow biopsy to exclude multiple myeloma. Treatment is with melphalan and prednisolone can delay progression to end-stage kidney disease. So amyloidosis, if we treat it early, will not lead to chronic kidney disease. So we have to diagnose early. Then I will talk about glomerulonephritis. We have mesangial proliferative glomerulonephritis, which is characterized by antibody deposition and increased numbers of mesangial cells. Can be seen in IgA nephropathy, which is also called Berger's disease. Idiopathic IgA nephropathy is rare in older adults, but secondary forms are more common. We have idiopathic membranoproliferative glomerulonephritis. It is very rare in older adults. This diagnosis should prompt a search for secondary inflammatory causes. So whenever we have membranoproliferative, we have to search for the cause in older adults. Therapy is based on the etiologic process. Then we have focal segmental glomerulosclerosis. Cases in older adults resemble those in younger groups, often a result of other glomerular diseases or secondary advanced systemic diseases like hypertension, diabetes. Some patients respond to steroids or cytotoxic agents, but long-term risk usually outweigh the benefits. Basic treatment principles: we have to correct the reversible causes, aggressively control blood pressure, use angiotensin converting enzyme inhibitors or angiotensin receptor blockers and aldosterone antagonist. We have to optimally control blood glucose in diabetic patients. We have to treat hyperlipidemia, minimize proteinuria, aggressively manage phosphorus concentration, and moderately restrict dietary protein. Excuse me. We have recognizing renovascular disease. We have to suspect renal artery diagnosis in cases of new onset diastolic hypertension, hypertension despite maximal doses of 3 antihypertensive agents, abruptly worsening hypertension that was previously stable, azotemia induced by treatment with an ACE inhibitor or angiotensin receptor blocker, hypertension accompanied by widespread vascular disease. The diagnostic test options: renal artery duplex ultrasonography, CT angiography, or magnetic resonance angiography. Treating renovascular disease, therapy is based on aggressive management of risk factors. Antihypertensive regimens should include angiotensin blockade. We have renovascular angioplasty plus or minus stenting. Renovascular angioplasty plus or minus stenting carries significant risk, particularly in patients with abdominal aortic atherosclerosis. In general, we have to limit invasive procedures. So we don't have to go to angioplasty and stenting, and we have to limit it to patients in whom medical management hasn't controlled blood pressure, or those who develop heart failure, and those with progressive decline in renal function. If it's not these cases, it's better to do manage non-invasive methods. Then introduction to acute renal failure. We have more than half of patients with acute renal failure are more than 60 years. There are 3 primary causes: pre-renal azotemia, intrinsic renal damage, post-renal acute renal failure. The blood urea nitrogen to creatinine ratio generally helps determine the cause, but may not always apply in older adults. If we have BUN, it's mostly pre-renal. Age is not an important prognostic factor. Dialysis should be promptly initiated to treat uremic symptoms and to prevent complications, including infection, heart failure, and bleeding. I will start with pre-renal azotemia. Hypovolemia is a major cause in older adults. Can also be caused or exacerbated by angiotensin converting enzyme inhibitors, angiotensin receptor blockers, NSAIDs, and alpha adrenergic blockers. We know like everything is declining in older adults, so reduced cardiac output also can predispose to pre-renal azotemia, most commonly from exacerbations of heart failure. Prompt treatment of underlying causes is critical because restriction of perfusion often results in recovery of renal function. Then I will talk about intrinsic renal disease, acute tubular necrosis. Ischemia is the most common cause in older adults. Evolution of pre-renal azotemia to frank acute tubular necrosis is more common in older adults with acute renal failure, and it's about 23% than in younger ones, which is 15%. Distinguishing pre-renal azotemia from established acute tubular necrosis depends mainly on analyzing urinary electrolytes and urine osmolality and carefully inspecting urinary sediment for granular muddy brown cast. We have treatment of patients with acute tubular necrosis generally supportive, depending on the cause. We treat it accordingly. Excuse me. One of the causes of intrinsic renal disease, the other cause is acute interstitial nephritis. We have NSAIDs, AC inhibitors, and more than 40 other medications have been implicated in acute interstitial nephritis. Commonly implicated antibiotics include, but not limited to, beta-lactam antibiotics, particularly methicillin, and fluoroquinolones, particularly ciprofloxacin. If the cause are drugs, we have to discontinue the offending agent. Rarely, a short trial of oral corticosteroids may be necessary when the interstitial inflammation is severe. Then acute glomerular nephritis. We have rapidly progressive glomerulonephritis. It's most common form in older adults. Many have systemic vasculitis. We have to consider progressive glomerulonephritis, rapid progressive glomerulonephritis in patients with acute renal failure and fever, weight loss, arthritis, abdominal pain, myopathy, cardiac disease, or CNS dysfunction. Therapy includes pulse steroids, cyclophosphamide, and plasmapheresis. We have other form, diffuse post-streptococcal acute glomerulonephritis occurs in up to 22.6% in patients more than 55 years old, and the prognosis generally favorable. We talk about acute renal failure and renal disease, then we will talk about post-renal obstruction, which is a common and often treatable cause of acute renal failure in older adults. Typical symptoms of urinary tract obstruction, such as urinary frequency, voiding difficulties may not be readily apparent in older adults. A careful review of medications, especially anticholinergic agents, can be useful in the case of post-renal obstruction. Renal ultrasonography and measurement of post-void residual urine volumes may be necessary to establish the diagnosis. Prompt urologic evaluation is warranted in cases of documented urinary tract obstruction. Chronic kidney disease, kidney function as measured by glomerular filtration rate declines 10% per decade after age 40 in 70% of the population. Progression of medical illnesses, especially chronic hypertension, often lead to development of chronic kidney disease late in life. Clinical progression of chronic kidney disease in older adults frequently manifests as decompensation of pre-existing medical illnesses, such as heart failure, diabetes mellitus, hypertension, or dementia. But as I said in the beginning, not necessarily have to be like comorbidity, but comorbidities will increase the chances and make it like faster to develop. Then we have 5 stages of chronic kidney disease. Stage 1, kidney damage with normal or increased GFR. And in stage 1, we have GFR will be more than 90 ml per minute per 1.73 meter square. In stage 2, kidney damage with mild decrease in GFR, and GFR will be 60 to 89. Stage 3, moderate decrease in GFR, and GFR will be 30 to 59. Stage 4 is severe decrease in GFR, and GFR will be 15 to 29. And the last stage is kidney failure, and GFR have to be less than 15 or dialysis. So the patient need dialysis. This will consider stage 5, sorry. Then we have principles of managing chronic kidney disease. We have to emphasize preservation of residual renal function using the same approaches as in younger people. Other treatment principles, we have to correct reversible causes, aggressively control blood pressure, use ACE inhibitors, angiotensin receptor blockers, and aldosterone antagonist, optimally control blood glucose, treat hyperlipidemia, minimize proteinuria, aggressively manage phosphorus concentration, and moderately restrict dietary protein. We have medications used in chronic kidney disease. So if a GFR less than 50, adjustment in dosage or dosing frequency may be needed. But if GFR is less than 30, almost all dosage need to be adjusted, especially for the following: analgesics, benzodiazepines, barbiturates, antispasmodics for both bowel and bladder, antihistamines, including diphenhydramine, decongestant containing ephedrine-related compounds, muscle relaxants, cardiac drugs, antibiotics. We know a lot of erythropoietin is produced in kidney, right? So if we have chronic kidney disease, the production of erythropoietin will be affected. So patients with chronic kidney disease will be susceptible to anemia. And how we can manage anemia? We have to screen for anemia starting at stage 3 chronic kidney disease. We have to exclude other causes of anemia before treating. Iron replacement should be the first step in treatment with a goal of raising transferrin saturation to more than 20%. Medicare guidelines require hemoglobin less than 12.5 gram per deciliter with hematocrit less than 39% to qualify for erythropoietin. Because erythropoietin have a lot of side effects. For example, it can cause hypertension. We have calcium, phosphorus, and bone disease in chronic kidney disease. All patients with glomerular filtration rate less than 60 should be regularly screened for calcium, phosphorus, and parathyroid hormone abnormalities. We have to maintain phosphorus concentrations between 2.7 and 4.6 milligram per deciliter in patients with stage 3 or 4 chronic kidney disease. Start dietary phosphorus restriction if parathyroid hormone is increased, even if the serum phosphorus is normal. So like to determine the treatment, we have we have to look about other factors like parathyroid hormone level. We have to use phosphorus binders as soon as parathyroid hormone start to increase. Because we know parathyroid hormone will increase loss of phosphorus. If vitamin D is prescribed, carefully monitor calcium and phosphorus. Bisphosphonates are recommended for osteoporosis associated with renal impairment, except in patients with dynamic bone disease, because bisphosphonate can increase the risk of bone tumor in these patients. Then the next topic will be managing depression in chronic kidney disease. We know in general, like depression is common in elderly. But in chronic kidney disease, we have to screen for depression for all patients. Why? Because diagnosis can be difficult. Vegetative symptoms can be similar to those of uremia or insufficient dialysis. Functional and cognitive decline are common presenting symptoms of depression in older adults with chronic kidney disease, and most depression screening instruments have been validated in kidney failure population. If we diagnose depression in chronic kidney disease patients, we have to very low dose of SSRIs, selective serotonin reuptake inhibitors are safe, but avoid the long-acting medications. Then nutrition is important aspect also for managing chronic kidney disease patients. Dietary requirements for patients with chronic kidney disease are complex. Intake of protein, phosphorus, and potassium all need to be controlled while maintaining adequate energy intake. Once a patient reaches stage 4 chronic kidney disease, an experienced renal dietitian should be involved in the patient's nutritional management. End-stage kidney disease is that which requires dialysis or transplant for survival. This is the term we use for end-stage kidney disease. More than 55% of patients with end-stage kidney disease are more than 60 years old. Some of the increase in renal replacement therapy indicates greater willingness to offer treatment to older individuals, but much is related to increases in remaining life expectancy with attendant progression of chronic kidney disease. So this diagram is annual incidence rates of treated end-stage kidney disease. On the x-axis, we have age, and on the y-axis, we have rates per million of population. So if we notice as the age is increasing from left to right, the rates will be increase of end-stage kidney disease. There is direct relation between increasing age and increasing rate of end-stage kidney disease. So in age 0 to 4, it's like near to 0. And if we go like immediate age 40 to 90, it's around like 300. The rate is around 300 per million. And if we go for the 70 to 79, it will be increasing like almost more than 1,400. In 80 plus, it start decreasing again. Because we know like in age, like if in very old age will not live long, because even if they don't have a disease, death from other causes will be due to age or other causes will be common. So this is why I think this is my explanation. If anyone have other explanation, you are welcome to put your input here. Dr. Nader, do you have any comment in this 80 plus decline?
Not right now. Thank you.
So then I will talk about dialysis in end-stage kidney disease. Age should be the sole exclusion criterion. Early referral to a nephrologist ensures adequate time for discussing options and for creating adequate access. Creation of a native arteriovenous fistula can require up to 6 months. So this is why we have to refer early. Hemodialysis and continuous ambulatory peritoneal dialysis appear to be equally effective in older adults, so the choice between them can be individualized. Dialysis to patients with dementia is controversial. Then I will talk about effect of dialysis on life expectancy in the United States. So we have the age and remaining life expectancy. Age 40 to 44 in dialysis population is 6 years. The remaining life expectancy 6.7 to 9.2. In non-dialysis population is higher, 30.1 to 40.8. Age 50 to 54, 5.1 to 6.9. And the non-dialysis population 22.5 to 31.5. Age 60 to 64, dialysis population life expectancy 3.7 to 5.1. In non-dialysis, it's higher, 16 to 22.8. 70 to 74, 2.7 to 3.5 in dialysis population and 10.8 to 15.2 in non-dialysis population. At age 80 to 84, dialysis population 2 to 24 in life expectancy, and non-dialysis population 6.9 to 8.8. So life expectancy is increased, is more in non-dialysis population. Then I will talk about kidney transplantation. As in younger patients, mortality rates in older patients with kidney transplant are considerably less than in those maintained on dialysis. Although older kidney recipients have higher risk of infection and sepsis than younger recipients, they demonstrate lower acute rejection rates and lower incidence of chronic rejection and greater survival probability than patients remaining on dialysis, even when corrected for levels of comorbidity. As we noticed that like the life expectancy in the previous slide will be more in non-dialysis patients. So it's better if there is any chance we can do kidney transplantation, it's better. Older patients and their families should explore the option of transplantation as soon as the need for renal replacement therapy arises. Then I will talk about end-stage kidney disease and hospice. In general, the patient will be transferred to hospice if life expectancy is 6 months or less. So regardless, of course, any patient like life expectancy more than 6 months will not go to hospice. So in almost half of cases, failure to survive is the driving reason for withdrawal from dialysis. Most people who withdraw from dialysis are more than 65 years old. About 20% of the dialysis cohort withdraws in any given year. The geriatrician have a unique role in educating nephrologists and patients about the value of hospice. Also, like in general information, hospice can be hospice care, it can be at home, it can be anywhere. But the idea is that, as I said, the life expectancy have to be 6 months or less. And the patient will not need like life prolonging treatment. It's like only supportive treatment to let the patient die in peace. Then in summary, the moderately impaired kidney can maintain normal homeostasis, but is unable to respond to a challenge. Care is needed when giving older patients salt and or water. Pre-renal azotemia, causing acute intrinsic renal damage, is more common in older adults than in younger ones. Serum creatinine is a poor marker of kidney function. Kidney function is best measured by the glomerular filtration rate. As I said, like a lot of stuff can affect renal creatinine. It is different between male and female, muscle mass, exercises, all this will affect creatinine level. So this is why it's a poor marker. Continuation of summary, we have chronic kidney disease is a disease of the older population and is classified into 5 stages based on GFR. Preventing progression of chronic kidney disease is important at any age. Referral to a nephrologist for patients with advanced chronic kidney disease is helpful for assisting with management and preparing for dialysis or a kidney transplant. Then we have 3 cases. The first case, the family of an 85-year-old woman takes her to an emergency room because of increasingly erratic behavior. Normally, she functions independently, but over the past few days, she has been forgetful, confused, and disoriented. History includes pneumonia 6 months ago, hypertension, and gastroesophageal reflux. Medications include hydrochlorothiazide, omeprazole, lisinopril, and multivitamin. Lab results show sodium 128 millimole per liter, potassium 3.2 millimole per liter, blood urea nitrogen 10 milligram per deciliter, creatinine 0.8 milligram per deciliter, urine sodium 80 millimole per liter, and urine osmolality 450 milliosmol per kilogram. The question is, Which of the following is the most likely cause of this patient's hyponatremia? Is it A, syndrome of inappropriate arginine vasopressin secretion or syndrome of inappropriate ADH? B, water intoxication? C, hydrochlorothiazide? D, omeprazole, or E, volume depletion and poor oral intake? What do you think?
Can you go back to the case here with the details?
Yeah, sure. Sorry. Yeah. This is a case. Okay, then I will go to the next slide. And these are the choices. Sorry, I have to go out. Like, I don't know how to do it, but I have to go out to see the chat. Anyone know, like, any ways that I can go to chat without going to the... Okay. A lot of people are saying A. 2 people say A. And it's C. Okay. The answer is C, hydrochlorothiazide.
Dr. Fatima, I'd like to welcome Dr. Ahmed Al-Donor. He is a nephrologist and he is one of the co-founder of this program. Dr. Ahmed, if you are available, can you shed some lights on this case? Thank you.
Welcome, Dr. Ahmed. Thank you for your support.
Hello, everybody. Hello, Nadir, all the attendees. And thank you, Doctor, for your very nice presentation. And this case is really one of the commonest diagnoses of electrolyte imbalance we see on daily basis. And if you see, this patient is an elderly, 85 years old. And this is by itself as a risk factors when you prescribe hydrochlorothiazide. And hydrochlorothiazide is the commonest cause of hyponatremia. So when prescribed such medication in this age group, first, because before prescription, look at the electrolytes as the kidney function, and then start with a small dose. Sometimes 12.5 milligram daily is just enough. Most patients could develop hyponatremia with a dose of 25. Also, in this age group, you have to pay attention to nutrition. Sometimes they have not enough solutes in their diet, and this is by itself will predispose them to hyponatremia. And also alcoholic patients, diabetic patients are prone to develop hyponatremia when prescribed hydrochlorothiazides. However, thiazides are good medications in treating hypertension, and also you can use them in chronic kidney disease. But when you deal with advanced chronic kidney disease, you better use loop diuretics like Lasix and trosamide, methacranic acids, and others. But you can use hydrochlorothiazides in patients with normal kidney function, with early stages of chronic kidney disease, which you really noted them very clearly at your comprehensive presentation. Thank you.
Thank you, Dr. Ahmed, for your input.
Thank you
Appreciate
so much, Dr. Ahmed. Thank you, Dr. Fatma. So from a geriatric point of view, what I do when I round with my residents or when I teach medical students is that the first thing in medicine we say, do no harm. In geriatric, what we say, any case in geriatric can be explained by a medication. So the first question in your mind when a presentation like this happen, you blame the medication. So first of all, any problem in geriatric can be explained by medication. So we want you to make sure you review your medication when you see the patient and see what kind of medication that can cause this type of problem. And if possible, remove it and then see what happens. So this is the first approach that's very common in geriatric in this country. So, and hopefully around the world, the medication is to be blamed when we have condition like this. Then you think about other possible causes. The differential diagnosis can come later, and then you can go over the details as far as the nephrology part, as Dr. Ahmed highlighted very well. Thank you.
Thank you,
Dr.
Nader.
Thank you, Dr. Ahmed and Dr. Nader, for your input. So, is it okay to move to the second case now?
Yes, please.
Okay. Case 2, we have an 80-year-old woman is admitted to the hospital with urosepsis. On examination, she weighed 6 kg, which is 132 pounds, and has a low-grade fever and increased respiratory rate. There is a consolidation in the right lower lobe. Lab results show normal electrolyte concentrations and a serum creatinine concentration of 1.8 milligram per deciliter, which is her recent baseline value. She responds well to 2 days of IV antibiotics, and cultures reveal E. coli sensitive to trimethoprim sulfamethoxazole. Your pharmacist reminds you that this medication requires adjustment for patients with renal impairment. I will give you a minute to look at the case before I move to the next slide. Take your time. Okay. Based on published equations, what is a patient's estimated glomerular filtration rate? Is it more than 90 ml per minute? Is it 60 to 90 milliliter per minute? Is it 30 to 60 or 10 to 30 or less than 10 milliliter per minute? What do you think? I don't know how to go to chats. Okay, unless I go out. Okay. D, 10 to 30.
Can you go back to the case, please?
Yeah, sure. Okay. Any input other than D? B? B. Okay. Okay, let's go to the answer. The answer is D. GFR 10 to 30 ml per minute. Yeah, Usman Ahmed, Dr. Usman Ahmed calculated 28, so it's 10 to 30. Dr. Nadir and Dr. Ahmed, do you have anything to add to case 2 before we go to the next case?
Okay,
Please
yeah,
go ahead,
yeah.
Dr. Ahmed, and
Yes, thank you. It is good questions. And this is like in your presentation, you mentioned the biomarker creatinine as a measure of the kidney function. So, and in this 80-year-old lady, it is 1.8. So it is relatively very high. And you can use CKD-EPI equation to calculate the eGFR, which comes between 10 and 30, as you mentioned, 28. And so the creatinine by itself is not a precise function. You have to look at he is a male or female, the muscle mass. Okay, is a patient, for example, has amputated lower extremities because the muscle mass is low. So there is many things you have to put in mind because before you say the creatinine is right, because sometimes even 1 milligram per deciliter is a high, and some patients with 1.8, really this is very high. So your patient has an eGFR of about 28, which is high, and which needs close observation and further intervention. This is what I can say about this case, but it is a very nice case. And the other thing is that your patient is on trimethoprim sulfamethoxazole, and this will lead to decreased secretion. It competes with the creatinine, so you find your creatinine is elevated because of this medication as well. Thank you.
Thank you very much for your input.
thank you, Dr. Ahmed. And again, this is a great case to present what happens as we get older. Body mass index, creatinine comes from muscles. As we get older, some of us might lose some of these muscles. So it's expected the creatinine will be lower. In this case, it's going up 1.8. So relatively, this is not tiny, but small lady. And we can use a calculator. I'm gonna just share the screen for a second.
Okay.
And this is one of the website that you can use. It's called mdcalc.com. And you can use creatinine clearance equation as mentioned. So you just click on female, you put the age, you put the weight, and if you have the creatinine, if you have the height as well. And here you can see it's about 24, as other fellow mentioned 28. So the calculation more or less it's similar, and the answer will be, as mentioned, between 10 to 30. So you think about older patients, and you think about what the changes that can happen. One more thing you think about is when you prescribe medication, as in this case, the pharmacist will remind you, hey, can you calculate the creatinine clearance? Because the dose might be adjusted. For Bactrim, for example, it comes with 2 doses, the regular dose and the higher dose. So when we treat with antibiotics like Bactrim, you think about what dose you should give this patient so you don't harm or cause problems. So you calculate the creatinine clearance, and depending on the cutoff, you will use which dose that will benefit the patient. And this goes along with other medication like Cipro, for example, or other antibiotics. Usually we will need to calculate the creatinine clearance to choose or select the best option or the best dose for the patient. Thank you.
Thank you, Dr. Nadir, for the input. Okay, I will share my screen now. Into the screen, right? Okay. Then we'll go to the next case, which will be the last case. Case 3, we have a 78-year-old man comes to the office because of left knee pain for the past months. His history includes long-standing hypertension, type 2 diabetes, ischemic cardiomyopathy, and chronic kidney disease. He is on hydrochlorothiazide, metoprolol, lisinopril, atorvastatin, aspirin, and glipizide. Blood pressure is 132 over 80 millimeters of mercury and pulse 70 beats per minute. Left knee joint is tender on palpation and effusion is evident. After 12 days of celecoxib, 200 milligram, like every 12 hours, the patient retains because of dyspnea, increased swelling in both legs, and fatigue. Blood pressure is 178 over 102 millimeters of mercury. Blood urea nitrogen is 71 milligram per deciliter. Baseline 38 was 38 milligram per deciliter, so it's increasing. Serum creatinine is 4.3 milligram per deciliter. The baseline was 2.1 milligram per deciliter, so also high. Urine analysis show low urine sodium, no cellular elements, and no proteinuria. I will give you a minute to look at the case before I go to the next slide. Okay. Which of the following is the most likely mechanism by which celecoxib caused acute renal failure in this patient? Is it A, drug-induced allergic interstitial nephritis, B, acute papillary necrosis with renal obstruction, C, drug-induced acute tubular necrosis, D, hemodynamic renal insufficiency, or E, nephrotic syndrome? Okay. We have B, A, and D. Any other input? The answer is D, hemodynamic renal insufficiency. If you go to this case, like if you notice, the one thing that we can exclude the problem in the kidney itself is like urine analysis, like urine sodium is not high, because if we have a problem in kidney itself, usually intrinsic kidney disease, not always, but mostly, the urine sodium will be high because the kidney is not working, right? So it is dumping sodium. So this is one thing that can give you a clue for the diagnosis. So this is hemodynamic renal insufficiency or pre-renal azotemia. Any input, Dr. Ahmed or Dr. Nader, for this case?
Yes, so this is a very nice case. So a patient has a CKD of baseline creatinine of 2.1 milligram per deciliter. And then it rose up to 4.3. She has acute kidney injury. So what are the causes? Here you look at the blood pressure, the medications, hydrochlorothiazide, metoprolol, lisinopril, atorvastatin, aspirin, and you look at all medications. And also you look at celecoxib, which is a selective COX-2 inhibitors, and it will cause renal vasoconstriction, and that is a cause of her possibly acute kidney injury, in addition to the other causes by different percentage, because she is diabetic and she has CKD. The non-steroidal anti-inflammatory medications, if you go back to the stem of the question, I also would like to discuss the other answer as well, please.
Yeah, you don't see the stem. This is a question. You don't see the question?
The stem, the answers.
The answers, okay.
Yes, thank you. So using non-steroidal anti-inflammatory medication could cause drug-induced allergic interstitial nephritis. Not necessarily you have to find eosinophils in the urine, but the best answer you could find is by renal biopsy. But usually we are not doing renal biopsies to diagnose allergic interstitial nephritis. And if it happened, you have to treat it within 7 days by using steroids, and the patient will recover. Okay, this case, and the other thing, acute papillary necrosis with renal obstruction. Non-steroidal anti-inflammatory medication can cause papillary necrosis. Okay, in addition to sicklers, patient with sickle cell disease could have papillary necrosis as well. Drug-induced acute tubular necrosis, this is like vancomycins could cause. And in our patients, vasoconstriction, it affects the hemodynamics of the renal blood flow. So this is a correct answer. And definitely it is not a nephrotic syndrome. Nephrotic syndrome, as you know, you will have nephrotic range proteinuria and the patient will be edematous. In all of this, there is a very important thing you have to know is the effective renal blood flow or the effective plasma flow. And this is when you have a patient with low blood pressure, patient with nephrotic syndrome, have hypoalbuminemia, and patient with heart failure. So you will not find a straight case where it fulfill only one diagnosis, but in this case, like the vasoconstriction played a major role. And but it is nice case. Thank you.
Thank you very much.
Thank you, Dr. Ahmed. And again, this case also highlight the aspect of the geriatric approach. So the patient to start with has multiple comorbid conditions. The patient on different medications to start with, and the kidney issue is apparent from the baseline creatinine. So it's important when you take history, if you can look at previous lab results to compare what the changes. So in this case, the change in kidney function, the creatinine rose from 1.2 to 4 or 1.8 to 4. So it's better to have an idea about the baseline, what the kidney function was doing before all this happened, like the condition change, the pain, the medication, addition of new medications. So this will highlight some of the importance of history taking and looking and reviewing the medical records. The second part I want to share is that with each new medication, you want to monitor closely because as I mentioned in the first part of this discussion is any condition in older adults can be explained by medication, the first to blame. So in this case, we will blame that medication and then investigate what happened. Sometimes this might not be the cause or this might not be the case, but it's better to be on the safe side. We don't want to harm patients while we are trying to help them. So just put that in mind. As we get older, things changes. So you need to pay attention. History taking is important. Review of chart, including previous labs, will help you guys. Thank you.
Thank you. Okay, now this is the end of discussion. I sincerely appreciate Dr. Nadir and Dr. Ahmed for contributing to the presentation and enriching our discussion with your valuable insights. Thank you for your guidance and support. And I thank you all for your time and attention. I appreciate your engagement and hope you found this presentation valuable. If you have any questions or anything to add, I would love to hear your thoughts. Thank you very much.
So now we open the floor for any questions or any comments. You can share your experience treating patients with kidney disease. But Dr. Ahmed, if you would like to add any more information about the topic, please go ahead. Thank you.
Thank you. This is a very important topic, chronic kidney disease. And as you all know, diabetes and hypertension are commonest causes of chronic kidney disease. So to prevent this, we have to have a good control of diabetes and hypertension. And the other thing is that dealing with a chronic kidney patient, you have to know the diagnosis, because it could be glomerulonephritis, it could be diabetes, hypertension, it could be other causes of rare renal disease like interstitial kidney disease, which runs in families. Always remember, in some patients, you might need to have a kidney biopsy early, and there is an indication. For example, nephrotic range proteinuria in adults, not necessarily in children. In children, if they are not responding to steroids, then you will do the kidney biopsy. But sometimes case-by-case basis. This is one thing. Kidney biopsy, put it in your mind. The other thing is that hematuria is very important. You have to do urine analysis, which some people called it water biopsy, and it gives you information. For example, hematuria, is it macroscopic, microscopic, is it glomerular, or it is from lower, like from the bladder? If it's lower, it could indicate something like it's called UTI or this RBC in itself is distorted, then you think glomerular. It could be due to many things. And IgA nephropathy could be one of that or others. If the patient has SLE, and with all that, and if you have a patient with chronic kidney disease, then you will follow. It is better to follow every 3 months, or sometimes even more frequent, okay, and until your patient is stable. You refer the patient to transplant if eGFR is 20. And now you're thinking of renal replacement therapy. The best is to do a kidney transplant from a living donor, and then from cadaveric kidney transplant. So that is before the patient could end up in dialysis. And if you do dialysis, there is different modalities. Proteinuria dialysis, don't forget about this. This is very important, and it could be done. It's convenient for some of the patient. The other thing is hemodialysis, which is in-center hemodialysis or home hemodialysis. This is another thing that could be considered. One of the most important thing is the access, and the presenter talk about it. The best thing is arteriovenous fistula, and it might need time to be well functioning. That is something you have to pay attention to. So these kind of things are important. Chronic kidney disease is very common, but as a practicing physician, you can do a good job and maintain stable function for years. Thank you. Thank you, Nadir. Thank you.
Thank you,
Thank you,
Dr.
Dr. Ahmed, for great tips and points. So one of the idea of this program is to apply this knowledge that we share in these meetings, and hopefully it will help you, your patients, your family members, your parents, grandparents, your loved ones in general, around the family or friends. So one of the thing is education. So you need to educate your circle around your family or others about the importance of over-the-counter medication, for example. And we can see it can cause problems, so you need to pay attention. I had a patient when I was resident who came up with just headache, and when he was asked about the medication he was taking Tylenol. So it's over the counter. It shouldn't be a problem. But the way he took the medication is that during the night he had this severe headache, so he took 2 tablets. After a few minutes, half an hour, he took another 2 tablets. By the morning time, when he came to the hospital, he has a lot of tablets in his system, and he ended up with end-stage liver disease. His enzymes were very, very high, so we ended up sending him to a tertiary center for liver transplant. So these medications, although in general it's safe, it can cause problems. So our intention in this program is to help you educate people around you to prevent things from happening. NSAIDs in general could be helpful, but in all adults, it can have some side effects, as mentioned in some of these cases. Medication is important to look at when you're taking history. It's better to be on the safe side to prevent things from happening. So controlling blood pressure, controlling diabetes will help either prevent or delay the progression of the disease in this topic, kidney disease. So I hope this will help you guys and help those around you. Thank you.
Thank you, Dr. Nader.
Thank you, Dr. Nader and Dr. Ahmed. Dr. Mohamed, if you are ready for the next presentation.
Hello, everyone. Is my voice clear?
Yes, it is.
Share my screen. Oh. Can you see my screen?
Yes, I can see.
Okay. Hello, everyone. I hope everyone is doing fine, and Ramadan Kareem. Thank you, Dr. Fatima, for your excellent presentation. Thank you, Dr. Nadir and Dr. Ahmed, for this opportunity and for this program and for supporting all of us. My name is Mohamed Sohaib. I'm an intern. Today is actually my first time presenting. I will be presenting this topic, understanding AI prompts. It's a fairly short and simple presentation. So if anyone has anything to add or any questions, please feel free. Okay. For introduction, I said we should define AI prompts. AI prompts are inputs or questions that you give to an AI model to elicit a response or to perform a task. What's the importance of an effective prompt is that it can improve the quality and the relevancy, you should say, of AI outputs and can ensure relevant, and useful responses. There are different types of AI prompts. Of course, you can give the AI a direct question. For example, what is the capital of France? This is a direct question with a direct answer. You can give instructional prompts where you give the AI a command or a task. For example, write a poem about the sea. You can give contextual prompts where you provide context for a more nuanced response. For example, in the style of Shakespeare, describe a sunset. And of course, you can have a conversation with the AI model where you engage in a dialogue. For example, like for starting the dialogue, you can say, "What do you think about climate change?" And then the AI will give you a response, and then you can engage in a conversation. There are some rules, general rules for crafting an effective prompt. One such is clarity. An effective prompt is clear and specific to avoid any ambiguous responses. For example, instead of saying, "Tell me about space," which is obviously not clear at all, you can ask, "Explain the formation of black holes," for example. And another rule that you should provide context for the AI. For the AI, if you want a more specific response, like, for example, summarize the plot of To Kill a Mockingbird by Harper Lee. This is contextualized prompt. An effective prompt should also be concise, where you try to avoid confusion. For example, list 3 benefits of renewable energy. This is clear and concise. You should also ask for relevance. For example, discuss the impact of social media on teenagers. This ties in more with context. They are more or less similar. Some examples for clear prompt, where you ask the AI to explain the process of photosynthesis. An effective response likely to be given by the AI will include a detailed explanation of photosynthesis involving chlorophyll, sunlight, water, and CO2. A contextual prompt, for example, will be like in 200 words, summarize the plot of To Kill a Mockingbird. An effective response would be a concise summary, including key characters and plot points. Or you can engage in a conversation by a conversational prompt. How can AI improve healthcare? An effective response would be a discussion on AI's potential in diagnostics and personalized medicine. Of course, it will be more like a conversation instead of just a question and an answer. Some common mistakes in AI prompting. First would be, of course, vague prompt, where it's too broad or lead to a broad or irrelevant response. For example, tell me about history. Of course, it's not very clear what you actually mean by this. An improved prompt would be more specific, like explain the causes of World War II or any other historical event that you are particularly interested in. Another mistake would be an overly complex prompt. Of course, this differs between AI models. Some might be better at doing this than others, but an overly complex prompt will confuse the AI and will lead to an incomplete answer. For example, explain the relationship between quantum mechanics and the theory of relativity in the context of modern physics. Of course, this is a very complex and unclear prompt. Improved prompts be more specific and clear, like describe the main principles of quantum mechanics. Another mistake would be lack of context, where the AI will struggle to provide accurate or relevant response to your query. For example, write a review. Of course, this is obviously not very clear at all. An improved prompt would be to ask the AI to write a review of the movie Inception, focusing on its plot and special effects. Some advanced techniques for prompting would be chaining prompts, where you break down complex tasks into simpler sequential prompts. For example, you would start with saying, explain what photosynthesis is. Then you would follow it up with describe the role of chlorophyll in photosynthesis. Then you follow it up with discuss the importance of photosynthesis for plant life. This is a very sequential and will most likely get you clearer answers for each one of the questions. Another technique would be role playing, where you assign roles to the AI for more dynamic interactions. And sometimes the AI can even provide context that you are not aware of. For example, you say to the AI, you are a teacher explaining World War II to high school students. This is an example of role playing. Another technique would be iterative refinement. where you gradually refine prompts based on AI responses to improve accuracy. For example, the initial prompt would be explain climate change, then you refine it to explain the main causes of climate change. Then you further refine it to discuss the impact of fossil fuels on climate change. Some practical applications of prompting, for example, content creation. You can ask the AI to write articles, stories, or poems. You can use it for customer support, where you make the AI give automated responses to common queries. It can be used for education or tutoring and explaining concepts. I personally use it for that. You can use it for data analysis, for summarizing and interpreting data. Like, for example, ask the AI to summarize the key findings from this or that paper or data set and such. There are many uses, of course, of AI. Those are some examples. Those are some tools and resources that you can use. The website or the app, I think, has a link to 50, I think, examples of excellent prompts that you can also check out. This concludes my presentation. So again, if anyone has anything to add or questions, please feel free. Thank you.
Thank you so much, Dr. Mohamed and Dr. Fatima, for a great presentation. Any other comments or addition to Dr. Mohamed? Dr. Ahmed, please go ahead. Thank you.
Thank you, Fatima, for the nice presentation about chronic kidney disease. And thank you, Mohamed, for the nice presentation about artificial intelligence. And excuse me, today I'm a little bit having a cold, so I might come across as my voice. The other thing is, yes, Mohamed, we need to augment our natural intelligence with artificial intelligence at some point. And so this is a very hot issue, the one you touched today. So the prompts are dealing with the models, right? So my question is, so say if we have a model, is this model by itself, is it going to excel as the time goes on? Because in artificial intelligence, the machines are always kind of in a mood of train and learning by the data they got. For example, like the prompting, for example, if they are using by many users, these machines or these models are going to get better and better. What do you think?
I personally think yes, Dr. Ahmed. I'm not like an expert in artificial intelligence or anything, but I think they are learning. They get better at understanding humans, and they get better at giving more relevant responses, and they learn. So I think most likely they are getting only better and better as time goes on. And of course, some models in themselves are more advanced than others. So yeah.
Okay, and thank you, Mohamed. There is a Harvard course on artificial intelligence, and I will recommend it for everybody. It is non-code course. You don't need to be a computer scientist to enroll in that course. And really, it gives us a very good introduction, and also you can do many things, and you will learn different software that you could use to use the artificial intelligence. It is non-code artificial intelligence, I think, by Harvard. I will share it, Nadir, with you, and you can share it, and we can share it with everybody. Especially in this era, practicing physician, researchers, clinician, scientists, you need an artificial intelligence. It helps a lot in our day-to-day life. For example, it just, you can nowadays, even the dictation, like the notes are being like in less than 1 minute. After you finish your encounter with the patient, everything is ready. And not only that, because the discussion, for example, Mohammed, between me and you, or between me and Nader, if, for example, I'm a patient and you are a physician, or vice versa, you can ask some question about drug history, maybe in a history of the present illness, or like some of the surgical history will come in the history of the present illness. So the AI, because it is trained, it can put any piece of information in its right place, because when it generates the notes, you will find that related to the drug history is there, and that relates to history of the present illness or surgical history is there. So artificial intelligence is the way to go, and it is going to change our life, I think, for good. Thank you.
Thank
Thank
you,
you so
Dr.
much.
Ahmed.
Thank you.
Thank you both, Dr. Ahmed and Dr. Mohammed. I'd like to open the floor for any of you guys, anyone worked with artificial intelligence. How did you do? What kind of things did you use? It's a tool, but how did you benefit from this artificial intelligence? Can you just say a couple of words? Any of your experience, guys? You can raise your hand if you want to participate. I'd like to have you engage in this activity. So I'm going to share with you how I use AI. For example, a few months ago, I was sitting for a board exam. So when I was preparing, when I have a complex concept or a topic that I need to understand more, so I use some of the tools like Gemini and or open source like ChatGPT to ask a question about a topic, about a case, about how did you solve this, or how to understand the approach to such a topic, for example. So for you guys, if you are planning to start to take step 3, for example, you can use it to help you understand some of the concepts or some of the questions, kind of, or it can create some cases for you. So you can list 5 cases for me about this topic, and then it will write just similar to the 3 cases we discussed, and it will explain some of the concepts that are common. So when you are asked in the actual test, maybe you will understand it better and you can answer the questions better. The other thing that I used it for when we try to submit an abstract or a manuscript. So what we do is some of you will work on a project, and at the end they will send it for review before we submit it to a conference, for example. So I run that by the abstract by the AI tool, and then I will try to improve that. So sometimes we may find some words that will be helpful, better than the one that we are using. So that's one way. Similar, I can use it to act as a reviewer. Let's say some of you wrote a manuscript and we are ready to submit that manuscript to a journal. So what I do is I use, similar to what Mohamed mentioned, some of the techniques. So I use a prompt. I'm gonna just tell you, for example, you are a reviewer for a big journal, and this is a manuscript that was submitted about this topic. Can you give me feedback about the areas that I can improve on? And you copy and paste the the manuscript, and it will analyze, and it will give you a feedback, and it will give you like what can be improved, what are the things that are missing, how can you highlight certain areas. And this will be very helpful instead of you submitting the manuscript and then wait for a few weeks, a month or so to get the reviewer feedback, and then you start on working on it. So it's instant feedback, so you can use that. Another one that I'm using when I created some of the resources, I ask it for a topic. Like I'll say, next week we will be presenting a topic about, let's say, artificial intelligence in medicine for international medical graduates. And I want you to write an outline for a presentation that's about 15 slides. So it will highlight the topic and the outlines. Then the next step, I will say, can you create the slides? So it will create the slides for me. Then the next thing I will ask, can you write the speaker notes? So it will add that as well. So it's kind of a step-by-step approach. And you can have the presentation ready in a few minutes if that what you want to do, for example. So this is how I approach this tool. Any one of you wants to share? Thank you.
Thank you, Nadir. This is really very helpful.
So we can move on to the next topic in the agenda. And one of the topics that we need to discuss is some of you will be applying, and hopefully you will get matched in the coming 2 weeks or so. We'll have the results. But I want you to prepare, if you didn't have any interviews, for the SOAP. And for that, if I can share the agenda item here. So we can look at the previous steps that people took when they prepared for the SOAP, when they apply for the residency. So in this app, you can find two topics or references, one in 2023, one in 2024. If you open one of these, you will go to the match steps and then the SOAP weeks or so. It will list some of the things that are required and how you will be ready for that week when it's going to start. So it will give you a background about the program itself, what has changed between 2023, 2024. And I think they will have one in their website for 2025. So you can just go over the policies. And then as an applicant, you want to go over the steps. Are you eligible for the SOAP, and what's a requirement for that process? So if you are eligible, I think you should be ready. You prepare all your documents or your stuff in the ERAS system, and you select the programs, you get ready. So by the time the programs open for the application, then you will be fast and send your application. So this is like the schedule. This for last year. This year it's gonna be more or less similar, but the date might be different. So the first Monday will have this, and then by Tuesday the results will be on, and then you go over the next details of what the SOAP will entail. So on Monday, what will happen? Tuesday, what will happen? and so on until Friday. I'd like to just advise you, if you are going through these steps, be ready to check on your emails and make your phone available, charged, and ready if they call you. Be ready for a short interview. Usually it will be like we will call you again in 15 minutes or half an hour, and the program director or some of the faculty will be ready to discuss with you to know you better. So be ready, and your phone is charged. If it's a Zoom meeting, if you have a computer, get that also ready. Thank you. If you have any addition, please go ahead. And Dr. Ahmed, if you have any comments. You are muted, Dr. Ahmed.
Hello, Dr. Nadir.
Yes, go ahead. Now we hear you.
Yes. No, I have nothing to add. But yes, I completely agree with what you have said, and nothing to add really.
Thank you so much, Dr. Ahmed. Any other addition or any other comments from other people? If not, we can move on to last item, maybe the updated about product updates. Any one to check? Anyone wants to share their updated project, any new ideas, and anything we can help you with, anything we can work on together?
Hi, Dr. Nadir. Osman Ahmed.
Sure, go ahead.
Just yesterday started sending email to the 13 member of the project number 70. Getting some reply, but I guess I'm waiting for the whole team just to see what their position, if they are ready to participate at the moment, and then we can just assign role for the member, and then yes, we can maybe we're gonna reach out to you to see for any advice when we get to the rule, like because most of us we don't have that experience in systematic review and this steps, but we will try to reach out here and there for senior and people we know, and also to you. So we just started.
Sounds good. Thank you so much.
Sure.
Thanks for the update and good luck.
Thanks.
So in the chat, someone asked about what the preferred tool of AI. I use both of all of them, actually. I started using ChatGPT, and in the beginning, ChatGPT, the first version was limited to 2021 and before that. So the data was not up to date, and then they upgrade their system. In the meantime, Google came up with Bard, and now their name is Gemini. So the difference was Google Gemini was up to date, so it can have access to the internet. So if you ask a question and there is some information that appeared between 2021 to 2025, then Gemini can access this information and give you feedback. So both of them I used, and recently there is DeepSeek, is a Chinese AI tool, and also it's very useful. I use it in different aspects. So I'm trying to build up some mobile application or understand some of the concept of writing some of these mobile applications, for example, without coding and sometimes with coding. So I try to self-learn. So sometimes I use more than one of these at the same time, because some of them might give me an error or a mistake and they cannot fix it, they cannot come over. So I apply the same concept of question to the second tool. If it's not working, to the third tool, and then I can have an idea of how I develop this app efficiently, for example. One of the things I was trying to do, we have new applicant to the program. They use one of the app that they enter their demographic information, let's say CV and address, contact information. And this is one system that I use to collect the information from the applicant and review their application and then approve and then accept them to the program. When accepted, we have a different system or different mobile app that I use, which is one that we just used for the agenda, for example, for today. So I need to use an efficient way of merging the data or pulling and getting the data into the new system. Usually I do that by copy paste, which is takes some time. There are different ways to do it. One of them is using the AI to merge some of the information. So I use it to help me with that. That can be done by humans, but it's better to use artificial intelligence to help with this process, for example. So I use different tools. DeepSeek is one of them, ChatGPT, Gemini. I haven't used Copilot, Microsoft Copilot as much, but all of them, I think they are very beneficial. But some of them may have some limitations. So you need to go over to apply the same concept or the question, the prompt, use the different tool. Most of them, I think, they have a paid version. You pay $20 a month, and then you can have more features. At this time, I did not need these features, but in your case, you might need it. Thank you. Dr. Ahmed, do you have any preference?
Really, Chat GPT is good, and Gemini to some extent, but I'm not an expert, so I'm just learning my way to learn these tools. But I think all of them needs to be tried before we can decide. But I'm very sure we will be in touch in future, and I hope the group one day we have whole sessions about AI.
Sure.
Thank you.
Thank you so much, Dr. Ahmed. And all this will be changing very, very fast. So it's better to keep up with all these changes, because whatever we learn today, next week, it might be an obsolete or it might be out of date for next week, any items or things that you want to do. Last thing I want to share with you is we worked on developing some mobile applications in the past, and we published them in Google Play and Apple Store. At least we have 5, and we have one under development about renal disease and patients with renal conditions. This app is under development, but the ones that we submitted and were published, for some reason, 3 or 4 of them were removed from the Google Play Store. So we need to work on getting them updated and then resubmit them to the Google Play Store. The one in Apple Store is still functioning and is still working. So we can just continue having that, or we can improve on it. It's a dental application, a dental reminder for patients with condition or some questions about dental issue. We can improve these applications by developing a similar version. Let's say the one in dental app in Apple Store is in English. We can work on developing the similar version, but in Arabic language or in Hindi language or whatever other language that you are good at. And we can work on developing that and then resubmit the mobile app to the store. This can be applied also to the other mobile applications that we already developed. So we need to either update them or get them into different version with different languages. So if you are interested, if you have some time, maybe we can get involved in developing this app, and hopefully we resubmit them to the App Store again. So we will be in touch in the future. Before we close this meeting, do you have any comments, any questions, any ideas, or any suggestions? Dr. Ahmed, do you have any? Thank you.
Thank you, Nadir. Thank you, everybody. Really, I'm pleased to share in this sessions for today, which are excellent. But in future, we can have a talk about AI. It will be all of us will bring their experiences, and Nadir, really, you have a great experience. Like the things you mentioned, you have been so far in artificial intelligence, I could tell. And you will be our resource dealing with this important issue, especially in medical fields. And also, Mohammed, your presentation is really very spectacular, especially when you mention something about astronomy, the black holes and all that. I'm very interested in AI, in medicine, and astronomy. I want to hear your comment. Thank you. Mohammed left? Nadir.
Maybe he left for a
Yeah.
second.
Yes,
But
hello.
go ahead,
So I'm
Mohammed.
sorry. I was just a bit busy. Sorry, I didn't hear the question.
Okay, yes, yes, sure. So let's put it in context. In life, and especially in medicine, we are dealing with to diagnose disease. We are dealing with very small things. We have to deal with molecular things, and at cellular level, molecular level, and AI is helping a lot in this. At the same time, with bigger stuff like the universe, the observable universe, and beyond that, we also need the artificial intelligence. And to my surprise, in your presentation, you mentioned the black hole. So, and that's really strikes something on me. So, I'm very interested in artificial intelligence, and I think it could solve problems as small as molecules and as big as the universe. So I just need your comment, and because you mentioned it, and I find it very interesting.
Well, Dr. Ahmed, I think that AI in general can help, as you put it, to augment our natural intelligence. So I think yes, it can surely help us with everything from the smaller, like everyday life tasks to like larger, more groundbreaking projects or innovations or whatever. So I think only time will tell to see if it truly will be like as big as a help as we think it will be.
Indeed. Thank you, Mohamed.
Thank you so much, Dr. Ahmed.
Thank you again, Dr. Fatma, Dr. Mohamed, for these great presentations. Thank you all for joining us. Thank you, Dr. Ahmed, for all the help that you are doing and the support and your comments and your tips. I'd like to thank all those who are in the meeting today and those who will come in the future to look at the recording or watch the recording. Thank you in advance, and we'll see you next week. Have a wonderful day. Thank you, and we'll see you next.
Thank you, Nader. Thank you, everybody. Have a good day.
Thank you, Dr. and Dr. Nader, and thank you for the listeners. Thank you very much for your guidance, doctors. Have a good one.